start with sort of talking about prevalence because the CDC came out with the new rates earlier last year. They revised their rates in March of 2012, and I bring this up because they did use DSM-4 TR criteria, which is the gold standard for clinical diagnosis. And in their report, which was published in March in MMWR, they basically looked at 14 sites across the U.S. And looked at essentially, reports based on kids who had already been worked up. So it was not a prospective, obviously, assessment. And basically the rates that were published in March were that 1 in 88 children nationwide met criteria for autism, which is a 23% increase from their 2009 estimates. Within that sort of estimate, the 4-to-1 male to female ratio held, but this then increases the rate in boys to 1 in 54 boys. There's a dramatic difference in sites in terms of diagnostic rates. So Alabama had a rate of 1 in 210, whereas Utah had a rate in 1 in 47. And the idea there is not that the rates differ that much by region, although there probably are some differences, but really that obviously the catchment and the actual diagnostic practices differ by area. Importantly, about 13% more children are being diagnosed by age 3, so more kind of early diagnosis, or diagnosis at the appropriate age. And based on this, the statement that was made in the paper, and I'm just showing this because the question always gets raised about why the increase in prevalence, what they essentially said was the extent to which this rise reflects better case ascertainment, meaning just more diagnosis, as a result of increases in awareness and access to services, or true increases in prevalence of autism symptoms is not known. So ASD continues to be an important public health concern. And that was sort of where it was left. Okay, so let's talk about DSM. What is DSM? The Diagnostic and Statistic Manual of Mental Disorders, which is published by the American Psychiatric Association. It's essentially the classification of mental disorders. Again, many of you clinicians in the room know this, but I'm just getting everyone on the same sort of playing field. And it provides us with a great checklist for diagnostic criteria for a variety of disorders, from ADHD to mood disorders to autism. And it's revised periodically based on our increased awareness and knowledge about the disorders. So DSM-4 was published in DSM-4 was published in '94, and then the revised version, which we use today, was published in 2000, and DSM-5 is due for publication in May of 2013, but was approved by the APA in December of 2012. So the DSM-4 TR criteria, the ones we use now, essentially describe core deficits in 3 areas: qualitative impairment in social interaction, communication, and the presence of repetitive behaviors. I'm again bringing this up so that I can highlight the changes in DSM-5. Also in the diagnostic requirements in DSM-4 is that you have to have evidence of delay or abnormal functioning in at least one of the following areas: social interaction, social communication as language, or play by age 3. So that onset by age 3 is part of the diagnostic criteria in the current DSM. So within sort of the pervasive developmental disorders chapter, there's autistic disorder, which I just talked about. Asperger's is essentially having the presence of repetitive behaviors and restricted interests and impaired social function, but no real history of language delay or abnormal language. Now, having said that, as many of us know, working with these kids, there are abnormalities in language pragmatics, but in terms of sort of typical actual language development and testing on language measures, that's considered in the typical range. These kids also cannot have had a clinically significant cognitive or adaptive delay. And then PDNOS, which is always the tough diagnosis, is by definition having severe or pervasive impairment in reciprocal social interaction plus either impaired communication or the presence of repetitive behaviors or restricted interests. So it's sort of sometimes people call it milder autism, atypical autism, but again, in DSM, that's the diagnostic differentiation of PDNOS. But as you all know, with autism comes many other, features. So, there's many other, comorbid areas that are very important in someone's functioning in a child or adult with autism. And I bring this up because this is actually addressed a little bit in DSM-5 as well. And so these are things like, again, ADHD, social phobia, and intellectual disability. And then all the medical features, which such as epilepsy being a big one. Okay, so DSM-5 was approved in December 2012, and there has been some controversy around it, which I'll get to in a minute. Please don't throw tomatoes at me. I wasn't involved with the development of DSM-5, but it really was, the criteria were really proposed by a group of absolute experts in the field. These are all the leading clinicians, clinical researchers really in autism, who got together and looked at data in terms of what would generate the most specific and sensitive diagnosis of autism, and that's where these criteria sort of come from. So I'm not, defending either way. I'm just saying that I'm just letting you know what's being published, essentially. And what's happening, the first big change is that these labels that we have, autistic disorder, PDNOS, Asperger's, will be gone. And instead, there will be one spectrum called autism spectrum disorder. And presumably, these children will fall under that category. What's the reason for that? Really, the ultimate reasoning for that was that it was found that these specific labels, like PDNOS or Asperger's, were actually not descriptive of a distinctive group of kids. And often, what was distinguishing, for instance, Asperger's from what would be called autism, or PDNOS from autism, was really IQ or other areas of functioning. So the kids who were considered higher functioning would sometimes be in the label of Asperger's, or sometimes would be in the label of PDNOS. And because of that, it was felt that it was more accurate to just describe a spectrum of disorders. Additionally, the two domains of social interaction, impaired social interaction, and language are being collapsed into one social communication domain. And to meet criteria for that area of impairment, you have to have deficits in social emotional reciprocity, deficits in nonverbal communication, and deficits in developing and maintaining relationships appropriate to that developmental level. So what was the justification for this? And many people in this audience, and people have already talked about this in prior talks, it's kind of hard to disentangle language from social function, especially in development, because so much communication is nonverbal, is not, verbal spoken language, yet it's communication, yet it's social interaction. And so the idea was that these areas are intimately related to each other. And also the idea was that by putting these together, it would de-emphasize language skills that actually weren't socially appropriate, if you will. So things like echolalia or scripting, where there's language, but it's not socially directed or socially appropriate. And then the second domain of restricted interest repetitive behaviors stays. The one highlight I have for you here in terms of a change is that they actually brought in a category, a subcategory within that for sensory issues, because that is such a prominent part of the clinical presentation in so many children. Now, you only have to have 2 of the 4 of these to meet criteria for this domain, but again, one of them that I highlight is hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So that's new in this DSM, and I'll give you a summary of the changes in a minute. Next, there is severity ratings. So you have the 2 domains that are the core deficits now in autism. And then within that, there's severity ratings. So from most severe to a normal variation. And really that severity is based on how disruptive it is. How impairing is the deficit in, for instance, social communication, or for instance, with repetitive behaviors. Most severe would be if you have a repetitive behavior that affects most activities, and it's very resistant to any kind of interference, as they call it, but really any kind of attempts to block it by someone else. So again, there's severity ratings in each of the domains. So to summarize, these findings, again, here's sort of the triad of DSM for TR, and in DSM-5, those 2 domains are basically going to turn into one. The diagnostic criteria are thus such: persistent deficits in social communication and social interaction, the presence of restricted and repetitive behaviors, symptoms. The next piece of the diagnostic criteria are symptoms present in early childhood. That's a change. So it was specifically had to have deficits by 3. Now it's been opened up a little bit. And the thought is that that'll actually bring in some more kids who maybe weren't caught earlier. Symptoms, of course, impair everyday functioning. There's a severity rating for each domain. And then getting at that slide that I showed you with sort of the comorbid medical and psychiatric issues, there's going to be specifiers and modifiers. So there'll be a specifier for cause. If you know you have autism because of Fragile X or because of tuberous sclerosis, that will actually be included in the diagnosis. And then modifiers for other important factors like seizure disorder or ADHD. And then there'll be an assessment of overall impairment. Now, again, those are sort of the details that some clinicians will use, some won't. I wanted you to sort of take home the point of the big changes that I mentioned. Now, there also is a diagnostic category that's being developed in DSM-5 called social communication disorder. This is not in your handout, but I wanted to add that in there. Again, I can give you these slides after the additional slides if you would like. Social communication disorder is considered an impairment of pragmatics, and it's a diagnosis based on essentially the difficulty of basically the social use of both verbal and nonverbal communication. And it's essentially the kids who, do not meet criteria for autism, and that's an exclusionary criteria. You cannot have autism if you have SCD. So if you have SCD, you don't have autism, but you have that social communication deficit without the repetitive behaviors, restricted interests, essentially, and that this cannot be explained by overall low cognitive functioning. So there was a big controversy when these were raised, when these were proposed. And part of the concern was that children who had a current diagnosis with DSM-4 would actually lose their diagnosis, particularly the kids who had a PDNOS diagnosis, and because of that they would lose services, which of course is not at all the goal of having an accurate, if you will, diagnostic set of criteria. And part of the controversy was stimulated by a paper that came out, it was early last year, by a Yale group looking at about 900 participants, and they looked at kids who had already been diagnosed by DSM-4, and they basically went back and applied DSM-5 criteria to their records, essentially, so to the history. They didn't look at all these kids again. And in their sample, what they found was only 60% of those kids would have met criteria for an ASD. Now, after that paper, there were many papers that came out that were much larger sample sizes that really looked at this question in more detail, because of course the APA would not approve DSM-5 with that sensitivity reported, essentially, and it was found that there were some big concerns with the way the diagnostic criteria were applied to that sample. The biggest study that actually was quite definitive in moving forward the approval of DSM-5 was a study by Kathy Lord's group that just came out in, I think it was March or April of 2012 in American Journal of Psychiatry. They looked at 4,500 children with DSM-4-TR, and these were kids who had been diagnosed with DSM, the ADOS, and the ADI. So they had records on all of those measures. And they went back and applied DSM-5 criteria, and they actually looked at DSM-5 diagnosis and how it actually matched up with not only the DSM-4 diagnosis, but also the ADOS and the ADI. And essentially, without going into lots of details, they basically found that DSM-5 identified 91% of the children with a DSM-4 diagnosis, and the ones that were missed, if you will, were actually ones that largely had a PDNOS diagnosis, and then instead of meeting an ASD diagnosis criteria, met criteria for social communication disorder. So these are more kids who had more of a language impairment and didn't really have what they felt as though was autism. So their conclusion was that actually, and I should say DSM-5 was more sensitive actually, or I should say matched up better with the ADOS and the ADI than the DSM-4. So they concluded actually that DSM-5 was more sensitive and specific to a diagnosis of autism than DSM-4-TR. And so based on that, the APA decided to approve DSM-5, and large organizations like Autism Speaks that were initially a little bit reticent about DSM-5 actually did make a statement that accepted essentially and supported the DSM-5 diagnostic criteria. But importantly, they did say that they sort of acknowledged it with cautious optimism, because of course what we need to do when the criteria come out in use, which will be this spring, is to look, to see prospectively, are there differences in diagnostic rates in the types of kids who are meeting, not meeting criteria. So there's a lot that will still need to be seen. But that was sort of a big validation, I will say, when Autism Speaks endorsed it. And so that's sort of the DSM-5 piece, and I'll just give one slide on this because I think it's relevant for diagnosis as we're talking about it, which is what is the recommended diagnostic workup for a kid who is diagnosed after using DSM-4 or DSM-5 with autism. So what's the standard guideline? And interestingly, both AAP, the American Academy of Neurology, Child Neurology Society, they've all actually put out recommendations, but they have not been republished since 2000. So they're due for updating, and they actually are in the works of doing that now. But essentially, bottom line is that the recommendation is every child with an autism diagnosis should have a genetics workup. What that workup means was actually left very vague in the 2000 AAN guidelines. They really, at that time, because the technology, as Dan Geschwin discussed, has changed so much, at that time really was focused on Fragile X testing, karyotype. Now we are recommending that every child have not only a karyotype Fragile X testing, but also MECP2 mutation testing for Rett syndrome, atypical Rett, and a chromosomal microarray analysis, or as if Dan was here, he would say whole exome sequencing. Of course, it depends on your insurance and capabilities, but every child should have genetic testing performed. MRI and EEG are only indicated if there's additional concerns. So there is an American Academy of Neurology guideline that a child with global developmental delay, which means not only language but motor delay, those kids should have a brain MRI. So if a child comes in to my clinic with autism and also has a history of global delay, has motor delay, then that's an indication to get a brain MRI, but not for autism in itself. And then an EEG is only indicated if, meaning a clinical EEG, if there is a concern for seizures. So having said that, we're going to now move on. 20 minutes, I did it. So I will take questions. The question was whether if a child has a regression, should they get an EEG? And what is being referred to is that there's a very small group of children, and it's a quite rare sort of phenomenon that have an epileptic regression, where there's fairly typical development. They develop severe epilepsy, usually seizures at night that are somewhat subclinical, and they lose skills. Usually the skills that are lost are language skills. And in that setting, you know, of course, anti-epileptics are very effective for putting them back on the right track developmentally. So if a child has a pure language regression, absolutely, I will get it. It's indicated to get an overnight EEG. The autistic regression piece is a little trickier. There are some studies looking at kids who have a reported autistic regression based on the ADI and looking at just EEG profiles. And more of those kids have abnormal EEGs. But the small studies that I've done to actually look at whether treating the EEG changes their development have not shown any effect. So if I hear a good story for regression, I will get an EEG because it's something that's so treatable if they do have epilepsy. But really, it's really clinically indicated only for a pure language regression.